All right, today we're jumping into a really interesting diagnostic puzzle, one that sits right at the intersection of immunology and what you see every day in the clinic. We're talking about how to diagnose HIV-associated salivary gland disease. So let's get right into it. Okay, so picture this. A patient walks into your clinic, they tell you the glands on both sides of their face have been getting bigger, but it doesn't hurt, and their mouth has been really dry. Now, this classic presentation could be a lot of things, right? But there's one specific condition that should be way up high on your list, and it could be the very first clue to a much bigger diagnosis.
And that condition is HIV-associated salivary gland disease, or HIV-SGD for short. It's defined by that exact picture: painless swelling of the big salivary glands on both sides, often with that dry mouth or xerostomia. Now, the absolutely crucial thing to remember here is that this isn't just some random symptom. It can actually be one of the very first signs of an HIV infection, sometimes showing up before anything else.
To really get a handle on this diagnosis and confirm it, we've got to go deeper. We need to go right down to the cellular level. So let's pull out the microscope and see what truly defines this disease pathologically. The absolute telltale sign of HIV-SGD is something called a benign lymphoepithelial cyst, or BLEC. Just think of these as little fluid-filled sacs that pop up inside the parotid gland. When we see these, we are definitely on the right track. They are the single most characteristic feature we look for. And here we go. This is a classic histology image of a BLEC. See that lighter area in the middle? That's the cyst itself. But look at what's around it, that intense, dark purple wall of super dense lymphoid tissue. This very distinct structure is exactly what we're talking about. So what makes this structure so specific? Well, it's all about its composition. The cyst itself, on the inside, is lined by epithelial cells. And then the wall is just packed, jam-packed, with a dense, overgrowing collection of lymphocytes. It's this exact combination, an epithelial cyst floating in a sea of lymphoid cells, that is the key diagnostic feature. Now, sometimes this whole process is part of a bigger, more systemic picture called diffuse infiltrative lymphocytosis syndrome, or DILS. With DILS, we're not just talking about a few isolated cysts. This is a massive infiltration of a very specific immune cell, the CD8 plus T lymphocyte, flooding into the salivary glands and, potentially other organs too. Under the microscope, DILs looks totally different. Instead of a nice, clean, defined cyst, you just see these waves of purple lymphocytes pouring into the normal gland tissue. It's a much more widespread or diffuse kind of process. Okay, so we've seen the pathology. Now let's zoom back out to the clinic. How do we start building our case for HIV-SGD before we even get a biopsy? What are the other clues we can piece together? The diagnosis really comes together piece by piece, kind of like a puzzle. Clinically, we have that slow, painless swelling. Then, on an ultrasound, we'd expect to see a bunch of dark, thin-walled cysts, and if we do a fine needle aspiration, we'd probably pull out this protein-rich fluid that's full of a mix of lymphocytes. Each step adds another piece to that puzzle. Okay, so all of these findings are highly suggestive, right? But they're not quite the smoking gun. They don't give us definitive proof of an HIV connection. So how do we clinch it? How do we tie these cysts directly to the virus itself? Well, the answer lies in a really specific lab test, an immunohistochemical stain. By testing the biopsy tissue for the HIV-1 P24 antigen, a positive result can definitively diagnose the cyst as being HIV-associated. It's the test that confirms the underlying cause, no doubt about it. Now, no diagnostic process is ever complete until you consider the mimics. Parotid swelling can be caused by a whole range of things. So let's run through the lineup of the usual suspects we need to make sure we rule out. First up on our list are tumors, both the benign and the malignant kind. And this is a really critical category to consider, especially since we know that patients with HIV have a higher risk for certain cancers. A lot of the time, telling these apart comes down to the clinical feel and the patient's history. For example, a lymphoma usually feels firm and grows really fast. A Warthin's tumor, we see that more often in older smokers. And a pleomorphic adenoma is typically just a single, firm mass on one side that's been growing slowly for a while. Okay, moving on from cancer, we have to think about infections. Plenty of bugs would love to set up shop in the salivary glands. The big giveaway here is usually how acute the whole thing is. A bacterial infection is going to hurt, there's going to be a fever, maybe even some pus. That's a world away from the slow, painless swelling of HIV-SGD.
Of course, viral causes like mumps are on the list, and so are granulomatous diseases like TB or sarcoidosis. But perhaps the most important, the most common, and the trickiest mimic of them all is an autoimmune condition that looks almost identical on the surface: Sjogren's syndrome. This head-to-head comparison is absolutely vital. The fundamental difference between them, the real deep-down distinction, it all comes down to the type of T cell that's driving all the inflammation. In HIV SGD and DILS, it's a CD8 plus dominant process. But in Sjogren's, it's the CD4 plus cells that are running the show. This is the core immunological difference. And beyond that T cell difference, there are other huge clues. Patients with Sjogren's are usually positive for autoantibodies, like SSA and SSB, which are pretty much always absent in HIV SGD. The patient demographics are different too. Sjogren's is way more common in middle-aged women. And finally, those hallmark cysts we talked about, super common in HIV SGD, but pretty rare in Sjogren's.
So, let's end with this thought. A patient comes in with swollen glands. And by correctly navigating this whole differential, a clinician doesn't just diagnose a salivary gland issue, they might be making the initial diagnosis of HIV. Catching it at this early stage can dramatically, completely alter a patient's life and their prognosis. It's just a powerful reminder of how a seemingly localized symptom can be the key that unlocks a massive, systemic diagnosis.